So hi everyone, welcome to Tulp County's webinar series. We are with Mustafa Sidik today, and he is presenting something on mean arterial pressure. We're very excited to have him, so thank you for being here. A little about Mustafa Sidik. He and I used to be partners in Cecil County, so that's
Yeah, we
one
did.
way that we know each other. Currently, he is the EMS Region 3 Associate Coordinator for MIMS. He has his bachelor's degree in biological sciences from Towson, and is currently pursuing his graduate degree in epidemiology from UMBC. Go UMBC graduate program. Um, he is currently serving in emergency services. He started off in Arbutus and then is now currently part-time with Cecil County. Currently, he is also adjuncting at several different colleges. He is at UMBC, Harford County Community College, and CCBC, which go CCBC, we all love that too. So whenever you're ready, Mustafa, we are so excited to have you here.
Yeah, thanks, Lindsay. It's funny you brought up, I ran an arrest at Arbutus for the first time, and I couldn't tell you how long. I think maybe at least 5 years, right? Because the pandemic, and I got a ROSC, and I took it, and my transport time was like 3 minutes, and it was so weird because everything else, in Cecil, I mean, unless you're like in Elkton or something, but yeah. So yeah, thanks for having me. How many people do we have?
Currently, we
Oh,
have,
five. Cool. Yeah, that's cool.
we'll take it.
Surprise. Yeah, no, it's cool. So, yeah, of course, thank you for having me. This discussion, this lecture that I started was one that we did at the Mid-Atlantic Transport Conference 2 years ago. And by we, I mean myself, Dr. Chismar, who's of course the stadium medical director, and Cody Winifred, who's the base manager for, I believe, oh, I'm gonna forget. I'm gonna say the wrong one, and he's gonna get mad at me. It's either PHI or stat medevac. I'm pretty sure it's PHI, but I could be wrong. But yeah, this has been a product of now, like I said, multiple years of developing this, refining this presentation, and the big thing I would say is I'm always looking for feedback. So whether if you have questions that come up during the presentation, feel free to stop me. And then of course I'm always open to critique. Just let me know, what I did right, what I did wrong, and what I can do further to just make the message clearer. In terms of acknowledgments, I really do want to acknowledge those two guys, Cody and Dr. Chismar. The work that we put in for that initial presentation was really, really useful in developing the framework that I'm going to use today. And then, like I said, I'm constantly looking to those guys for guidance and just seeing what we're doing right, what we're doing wrong, and yeah, they deserve to be acknowledged. In terms of sources, this is something I started doing last year because it's easy for me to just throw on a works cited page with just a ton of words. But when people actually see the resources that I use, not only for this presentation, but something that I use every day to refresh whatever random physiology topic that I want to read about, they're super useful. And especially for the folks, I know the folks that are listening can ask, but for the folks listening in the room, the book on the top left, written by Dr. Eric Sildorf, who is one of my mentors, who really taught me the utility of functional physiology and understanding why a disease presents in the first place before we go treating it. And we'll dive into that a little bit better. Dr. Andre Mansour is an internal medicine guy out of OHSU, the Oregon Health Sciences University. Reading his textbook, so one of my best friends was in medical school. Now he's a neurosurgery resident there. Dr. Mansour was one of his mentors, and I got the opportunity to meet him. And the way he displays and the way he processes through assessing a patient, coming to a good diagnosis and then treating, it was eye-opening to me. So I certainly would recommend that. The other two books, I mean, so the endocrinology book by Hadley and Levine was crucial in my own education for functional physiology. And it kind of changed and it really helped me reframe how I learned and taught myself physiology and how I approached, medical issues, problems, clinical diagnoses. So certainly a useful book. And then I think everyone in EMS at this point probably knows Life in the Fast Lane, and then Stat Pearls is Stat Pearls. So the goal of today, I could have given you, and I probably should have done like a generic objectives slide, but this presentation was thought of from me as a paramedic, knowing that mean arterial pressure is an important metric, but not understanding the why, not understanding it apart from just a static concept. And once I went to, or I should say, a static vital sign, once I had the opportunity to get, go to higher education and learn the underlying variables that make up the mean arterial pressure, I thought, wow, this is no wonder the treatments that we do work, and no wonder our patients present the way they do. So this is intended to provide the layer of information underneath what we get in basic anatomy and physiology. And hopefully by the end of this, folks have a better understanding of when they go see someone who's presenting in shock, why they're presenting in that way, and what they're doing, what we can do as clinicians to improve that outcome. It's going to be two parts. We're going to talk about the MAP physiology first, and then we'll dive into pulse pressure. But let's get started with MAP in general. So usually I do this presentation with a ton of people in the room, and when they don't answer my question, I call on them. So I'm going to call on you, Lindsay. Actually, no, we'll call on Ashley. Ashley, what does shock mean to you? Bueller. Lindsay, you can go too if you like. I don't know if she's struggling to go off mute.
So what does shock mean to me? So serious vital signs changes and potential collapse of the circulatory system.
I like it. I like it. Who else is in the call? I feel like there's one more person that.
So Shelly can answer your questions too.
Shelly, go ahead, please.
Hi, sorry, I was trying to figure out how to unmute. So I would say shock would be, for me, like Lindsay said about the serious vital signs changes, the lack in the blood flow, depending on what kind of shock, things like that, I would guess.
No, I really like that, Shelly. The big one that I like is when you mentioned the lack of blood flow. So when I think of, and we'll get back to this analogy later in the presentation, but when I think of shock, I really think about me trying to wash my car, and for whatever reason, water's not getting to the end of the spigot, right? There's a variety of issues, but the overall issue is I can't wash my car because there's a lack of flow. For our body, everything that we are, all of our organisms are the smallest, all of our organisms, all of our organism, the smallest unit of function is a cell. And that cell needs a bunch of things to function appropriately. We need to get oxygen to those cells. We need to get nutrients to get to those cells. But we also need to get stuff out of those cells, right? The CO2, other byproducts. And keeping our bodies at a particular set point is called homeostasis, right? And if everything is good, we stay at this set point and things function properly. You're able to go to work. You're able to go to see the Orioles lose. You're able to do all these things. But when we have a drop in perfusion, right, and a drop of for whatever reason, that's when we see those that drop in MAP and then the resulting diseases that come from that. Why do we use MAP as opposed to just a systolic blood pressure? The systolic blood pressure it comes from when blood is ejected from the left ventricle, it goes through the aortic valve into the aorta. That aortic pulse is created. The peak pressure of that aortic pulse is the systolic pressure, but it's really just a one static variable, right? When I think of a mean arterial pressure, the mean arterial pressure is I really think of it as the driver behind blood flow and the actual driver behind organ perfusion. And it just gives me more information. Where the map to me is telling me how severe my patient's shock is. And when we see like these really crappy maps, that's when we're starting to be more concerned as to the severity of my patient. Just a quick review on the four basic types of shock. We're going to dive deeper into this. Of course, we know distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock all cause shock and a reduction in MAP in different ways. And helping or knowing how to efficiently differentiate those issues and treat accordingly, I think is a core underlying principle of EMS, especially because of how early we're seeing people, hopefully, and where we're functioning and what kind, where we're providing the pre-hospital medicine that we're providing. The one could argue that just the surface understanding of what's driving the shock is useful, but in my own personal experience, there was a significant lack of diving deep into the why. And so after, like I said before, myself and the folks that presented this stuff before me, we wanted to provide some sort of deeper information as to why why the shock is presenting in the way it is and how we can help fix it. In this presentation, we're going to look at this, this three-step process. The first step we kind of already do, right? Everyone at some point, hopefully, is taking a manual blood pressure or throwing the life back on and hitting the NIVP button. And we're trending vital signs. That's something we do every day. Maybe we're not paying as much attention to the mean arterial pressure. And I'll tell you right now, even today, while I'm presenting this, I think I picked up a shift on Sunday at Cecil. I'm not routinely checking or even thinking about the pulse pressure. It's something that I have to prompt myself to do. But what these two things can give us, the map can show us the severity of someone's shock, and then the pulse pressure can tell us why that patient is in shock. So I know I've been moving a little fast. Lindsay, if you need me to slow down, speed up, just please let me know. Okay. All right. So let's dive into the actual physiology. So I talked about the car washing analogy. So the first ever job I ever had, I think I was like 10 or 11 years old. My dad was a mechanic at a car dealership. And it's really happy memories. You can see me smiling. The guy that I thought I was the richest guy in the world, the gentleman, the owner of the shop, would give me $5 a car to detail, right? And it's a car dealership, so it's not like he would just let me, throw some water on it and I get the $5. Like I think it's probably one of the hardest I've ever worked. And I just remember that the hose never had any good water pressure. And when we were talking about this, fast forward how many years to my human physiology course, we were talking about this, and I was like, man, I'm going to use that analogy when I teach. This V equals IR, so voltage equals current times resistance, is this relationship is found throughout life, throughout physiology. When you're thinking of like, say, nerve conduction, right? It's there. When you are thinking of blood flow, which we're obviously going to talk about today, you see this relationship between when I think of flow, something wants to move through a closed space, and resistance is the force that's trying to stop it. Offensive lineman pushing against a defensive line, right? This is a concept that you'll see everywhere. So the product of the flow and resistance is pressure. The example that I use is If I don't have a good enough pressure because I don't have a spigot for whatever, or not spigot. I keep using spigot. The thing at the end that you put on a garden hose, you put your finger on part of it, right, and it'll get you the pressure you need. That is a great example of flow being not you're not changing flow, but you're changing the resistance, and because of that, pressure goes up. This can be directly extrapolated to the mean arterial pressure, and each of these are. Oh, why is that loading? Are you still with me, Lindsay?
Yep, still here.
Okay. Did it pause on your screen?
So it did pause and there's a circle, like a thinking circle. Okay, you're good.
There we go. Okay, that was weird. Okay, cool. Thanks. All right. So where was I? Yeah. So that V equals IR directly uh, uh, is related to mean arterial pressure. The pressure being, oh, I guess probably because there's a latency issue, it's not going to do my videos. That's going to suck, but it's okay. So in this relationship of mean arterial pressure, the flow is described as the cardiac output, and the resistance is the systemic vascular resistance. For the nature of this presentation, we're gonna negate. We're not going to talk about central venous pressure. Quite frankly, it is certainly significant, and I think if Liz Wooster was on this call, she'd probably dig me a little bit. But she's one of my mentors at MIMS. But for the purposes of this conversation, we're not going to talk about central venous pressure for now. So let's dive into what the different components of cardiac output and systemic vascular resistance are. So cardiac output. Cardiac output is a function of, which means it's a product of stroke volume and heart rate. So what is stroke volume? Stroke volume is the difference of blood that is, so you take the amount of blood that your heart has when it's filled all the way, right? That's diastole, and you subtract how much blood is there at the end of systole when your heart beats, right? So that's the stroke volume, how much blood is going in. It's a product of basically how much fluid is going out and how many times that fluid is being prompted to go, right? Heart rate. That's what goes into your cardiac output. The systemic vascular resistance has three main things that affect it. Of course, vascular diameter, right? So if you're, I'm sure, hopefully, you have some firefighters end up watching this. Like your 5-inch, it has a different diameter than your deuce and a half, right? So it's gonna flow a different way. The length, right? So for our pump operators, length and friction loss is a major issue. Same thing with the vasculature inside, and the anatomical arrangements of blood vessels, how things are arranged. So when I took a lift to my hotel here in Miami, their highway arrangement is insane, and the traffic was insane. So, and the last thing, of course, is blood viscosity. Just think of it as how thick blood is. All of these things in here, let me go back for a bit. I thought I had no, it's okay. All of these things contribute to how much blood is going to go out of the heart versus how much resistance it's going to meet. At this point, I know this is, we've talked about a lot. So what I'd like to do is you do case studies to show how this ends up actually presenting in the field. So traumatic hemorrhage. We go back to, you have a patient, their car's on their side, they have a significant laceration, and because of that laceration, they start bleeding, right, from wherever they're bleeding, and because of that, the end diastolic volume goes down, right? So because of that, stroke volume goes down because the amount of blood that's coming back to the heart's going down. So of course the blood that's going to go out of the heart is also going down. Because of that variable going down, the resulting variable, the pressure, also goes down. And that's pretty self-explanatory. How does our body fix that? Well, It's a number of ways, right? So our body, we know that when we see someone who's in hemorrhagic shock, how are they presenting? The really sick ones are tachycardic, right? Because the body can't necessarily, it does try to fix the stroke volume by um, your blood vessel compression and stuff like that, but it's trying to do multiple different things to alleviate that drop in mean arterial pressure. So to get that overall variable up, it's going to release, epinephrine, norepinephrine, and because of that, we know the heart rate goes up. And the goal of our body is to get that map up. So this is also relevant on how we're treating traumatic hemorrhage, especially today with as of today's recording, I believe we have two systems two jurisdictions that have whole blood, Maryland State Police and Howard County. How are they fixing this? How does that treatment fit into this? We're increasing stroke volume, right? Because we are repleting the body with the exact substance that it lost. Because we're bringing that number back up, and the heart rate is already compensating a bit, hopefully we get some preservation of the mean arterial pressure and increase in mean arterial pressure so that we can get that patient to definitive care. Of course, ultimately, they need to close the hole, right, so that the system can not continuously lose blood. But that's one example of how this relationship of cardiac output and systemic vascular resistance contributes to mean arterial pressure. Another relevant case is in terms of, and I use atrial fibrillation with RVR, at any rate, 130 and above, or, I've seen a little bit lower than that. But for the cases of this conversation, any arrhythmia that's causing a decrease in blood pressure, you could replace this with any tachycardia and you could see it. So basically, well, how does this work, right? The same thing. Because of the heart not being able to fill, right? And how does that happen in this equation? Because the heart's beating so fast, it doesn't have time to fill. Stroke volume, end diastolic volume goes down. Because of that, stroke volume goes down. And of course, the resultant reduction in cardiac output also then contributes to the mean arterial pressure going down. Now, how do we fix this? We give some sort of agent to do rate control. So for this, you have a calcium channel blocker that works in a few different ways. Of course, we use it for the calcium channel blockade that then helps get the heart rate down. There's also, I believe, there's other things that it does that we don't necessarily need to talk about. But the general example that we give here is so that we can hopefully get an increase in mean arterial pressure. The same thing is when we are electrically cardioverting, right? Or synchronized cardioversion. Because we are giving that hard reset, that heart rate is getting corrected, right? Because the problem here is the heart rate. Because fixing the heart rate is going to help hopefully get us more blood back into the heart, and you can have more stroke volume to get a better cardiac output. As an aside, I was debating if we should bring this up or not, but I think it's a good learning tool. Sometimes you'll see a patient, and these are, in my opinion, some of the more riskier patients to give any sort of rate control agent to. When you have a patient in AFib RVR that has a blood pressure that's kind of soft, like 100, 110, it's concerning to me because technically, right, we could drop that heart rate too low and have a resulting drop in mean arterial pressure. It's especially crucial to be careful giving any sort of calcium blockade in patients that have heart failure, because there's really two kinds of heart failure. And maybe I don't want to necessarily go too off the script here, but the reason that protocol has a little thing that says caution, and we're working on changing the verbiage to increase the caution that folks take, is there's two kinds of heart failure. There's people call it systolic and diastolic, and the other terms are heart failure with preserved ejection fraction, and then with loss of ejection fraction. The systolic folks, systolic heart failure folks, they are very reliant on their heart rate and their intrinsic mechanisms for correcting for the damaged heart. If we provide calcium blockade, what's going to end up happening is we take out the very survival mechanism that they've developed to preserve their mean arterial output. To us, we may think that we're treating, and to be clear, this is not in someone that has AFib with a rate of 180, right? These are the AFibers at 110. These are the AFibers at 115. But a clinician might mistakenly think that that's something they need to treat. And when they treat that and both the heart rate goes down, and the heart rate goes down, that resultant drop in MAP could be catastrophic because they don't have the other mechanisms to preserve their cardiac output because of the heart failure. One of the big reasons I think that, and this is a recent practice that I've had, if I'm giving cardizem, I have calcium next to me. It's not in my bag. It's not in the drawer. It's ready. I'm not opening it because that would probably really upset my supply folks wherever I'm writing, but have it ready, have it there. And if I see a sudden change in mental status because of a drop in pressure, I'm giving that antidote right away. It's just a good practice to have. I hope I didn't lose folks on that sidebar, but I think it also helps explain why this relationship works. And like I said, if anyone has any questions, please stop me. All right, so we've talked about ad nauseum why MAP is useful. As a quick review, it's an indicator of how severe shock is, and also we talked about the different components of what go into the mean arterial pressure and what contribute to that pressure. Let's talk about pulse pressure next. So we all know, we already kind of talked about what goes into blood pressure, right? The systolic blood pressure, think of it as like cardiac function. Diastolic blood pressure, think of it as like the filling pressure and like the status of the systemic vascular resistance and vascular tone. A normal pulse pressure is about 40. You get it by subtracting the diastolic blood pressure from the systolic blood pressure. And how do we interpret it? So if it's greater than 40, you have a wide pulse pressure, and the less than 40 is a narrow pulse pressure. So going back to that framework, we know how to figure out the MAP, and we have this information of how severe the shock is. Now we can start looking at why the patient is shock. That of course matters, because then if we know why something is happening, we can treat that. The next few slides, you'll see there's a drastic change in the formatting. They're actually from Cody, and I really like how he set these up. So we're gonna, I just decided to use these, of course, with his permission. And this is a great slide right here. If folks don't listen to anything else, right, or if they don't take anything else home, this is really useful, and this was eye-opening to me because it differentiates essentially two things. Is the pulse pressure wide or narrow? And if it is there, if it's a wide pulse pressure, is there tachycardia or is there no tachycardia? Now, it helps at least for me, to think about specific cases where this might occur. So the big thing that I think about is an obstructive shock in say tension pneumothorax, right? So we arrive on scene, say there's a pedestrian struck, and actually no, we'll use an example of a call that I actually had. So this was a gentleman who was T-boned, and I arrive on scene, and he's already in the ambulance. He's diaphoretic, tachycardic. He's having respiratory distress, and he's having he's sick. As a little sidebar, there's a physician by the name of Almu. He's a emergency medicine physician at University of Maryland. He always says, if your patient is sweating, right, unless it's like hot outside. If your patient's sweating, you should be too. And diaphoresis is very concerning. And I remember seeing this patient, I'm thinking, oh wow, this guy's legit sick, especially because it wasn't like hot outside. What is the actual issue with a tension pneumothorax? Why is it a problem? Well, what's happening is you have air in your chest cavity, and with the increase in air, think of your chest as a closed cylinder. With increase in pressure, right? Going back to the systemic vascular resistance, right? There's that number's going up. So because that number is going up, we are really pushing against the left ventricle, and blood's not going out, right? Because it has to work harder to go out. Eventually, so of course, pneumothorax is just when there's that damage, right? Tension is when it's actually causing issues. It's really obstructing blood flow from going out, and that's why we see the tachycardia, because that's how our body's trying to compensate for that increase in pressure. That's why for really bad cases, we see this hypotension. And how do we fix that? Of course, we do a needle decompression to release the pressure, right? And because of that, you're releasing pressure off of that left ventricle, and you're hopefully reinstituting at least a temporizing measure to fix that pressure against the left ventricle. The other example you can think of is hypovolemic shock, right? We already talked about that. So again, like I said, this is the slide that really helped me understand it. And this is a recording, so you'll have access to this. But maybe, Lindsay, I'm happy to share my slides too if people find it interesting, and if it helps folks study. Moving on to the wide pulse pressure.
Yes, please, on the slides, if you could.
Say that one more time.
If you could share the slides,
sure,
that would be really helpful.
Sure, of course,
Thank
absolutely. You. On the other side of the table, you have the wide pulse pressure with or without tachycardia, and it was intuitive to me because in terms of the sepsis, right, or anaphylaxis, I think of you going from inch and 3/4 hose to a 5-inch hose for a primary attack line on a fire, right? For it's not functional, right? It's not good. You don't have enough pressure to get fluid to where it needs to go. That's why our primary treatment options are crystalline, right? That's why we give so much fluid, because we're trying to fix this systemic vasodilation because of the disease process. That's why for anaphylaxis, what's the biggest treatment that we're going to give? Epinephrine. Why do we give epinephrine? So there's epinephrine, of course, has the beta 1, beta 2 effects, right? So, but also there's alpha 1 receptors are what control the size of blood vessels. For an anaphylaxis, when the blood vessels get get larger, the epinephrine is helping clamp those down. There's also some other activity that I'm not talking about with mast cells and stuff, but we don't need to talk about that for the scope of this conversation. But again, like I said, it helps, number one, us diagnose why we treat things the way we do and why folks are experiencing the shock they are. But on the other end, it helps us understand how our treatments are also affecting them. Let's see. Oh, skip too far. We kind of already talked about this. The concept of cold shock versus warm shock. This is actually something I'm going to ask Dr. Chacon at the end of the presentation, because I've heard that there is some controversy over using that terminology. I personally don't have an issue with it, but I had some grumblings at one of my last presentations. So, but this is basically what we kind of already talked about. Let's see. And I know oh yeah, I got time. We're good. So let's bring this home. I know I've given a ton of information, and I know I have a tendency to talk too fast. So, and we'll have plenty of time for questions. What have we talked about so far? What's the point of this conversation? We today have described that the mean arterial pressure is a crucial tool in understanding how serious someone's shock is. The bottom number, that shock, the bottom limit that we're looking for is like a MAP of 65, right? Below that, we're starting to get concerned. The understanding the relationship between stroke volume and heart rate as it contributes to cardiac output, and understanding the relationship of cardiac output and systemic vascular resistance as they contribute to mean arterial pressure is crucial in understanding, like I said before, why our patients are experiencing what they're experiencing and why our treatments are helping them. This helps with critical thinking so that if you say see like I said before, an atrial fibrillation, but it's in a rate of 100 or 90, and your patient's having some sort of complaint, you know, as a clinician, that heart rate is not what's contributing to their distress, because we understand the normal parameters of heart rate. And since they're within the normal range, they're not going to affect that mean arterial pressure. We stress that just like systolic blood pressure by itself is not a great tool, because it doesn't provide any sort of dimension as to what's actually going on with the patient. The mean arterial pressure with the pulse pressure helps us diagnose the severity and the reason. Of course, in tandem with a good physical exam and a good history taking. I wanted to leave this slide in here because another one of the lectures that I do really dives into the physiology of waveform capnography and why it's useful. It's a great. The reason I wanted to leave this in here was because I'm a huge proponent of using waveform capnography. When I first started as a paramedic, well, technically a CRT, a cardiac rescue technician, we were not allowed to use end tidal except for capturing if a tube was in. And it blows my mind, because now I'm pretty loose and pretty liberal with my end tidal, because it gives me a ton of information. Not only it gives me an accurate respiratory rate, but also it gives me a ton of information of my patient's underlying physiology and perfusion. And it's a great tool and works very well in tandem with actively monitoring a patient's MAP and pulse pressure. The other thing I like in here is your SpO2 is only as good as your perfusion, and as soon as you're in a shocky state, you can't really trust your oxygen saturation. If your patient's MAP is like 41, right, or something bad, I am not trusting that oxygen saturation. I am looking at the end tidal, and I'm looking at my patients. I'm actually assessing my patient and seeing their comfort level. So that's just the other plug that I wanted to include for that. In summary, I know, like I said, we went through a lot in a short amount of time. The big things that I want you guys to take home is number one, like we already talked about, the utility of mean arterial pressure and pulse pressure, but also, like I said, I'll send out the slides. The two frameworks. Number one, getting a systolic blood pressure, getting the MAP, and getting the severity to see the severity and the cause, but also the relationship of the pulse pressure and the presence of tachycardia or not. Those two things are so useful to get a snapshot of how sick my patient is and what we can do to fix it. So that's what I have. Oh, and we're doing really good on time. I like to have 15 minutes for questions. So yeah, what questions do folks have for me?
Yeah, so feel free to ask questions if you want to just unmute yourself and ask. But if you are feeling shy, feel free to ask in the group chat. I'm going to be monitoring that, and I can ask for you.
I think Dr. Chacon raised his hand.
Mustafa, I would like to say that this was an elegant presentation.
Thank you.
You took this is clinician level education, and you have taken some very heady concepts and presented them by making baby steps in understanding. And I particularly liked the slide that showed the relation. The SVR on this side is up, and that's equals this kind of shock. SVR is down. I thought that was really, really good. But overall, I'm a fan. It was a very non-threatening presentation. And this is heady stuff. It's easy to get intimidated by this. So I'm enjoying this.
Thank you. I appreciate that. And really, for that slide in particular, really goes to Cody and his colleagues. I thought the same exact thing when I saw it for the first time. I said, "Oh wow, this is perfect. I'm gonna utilize it." But thank you. What other questions do you guys have?
Anyone else? Any other questions,
And comments?
concerns, thoughts, emotions?
Yep.
I don't have any questions. I would really like to have the slides if that's a possible thing. I think that it was a really good lecture and I learned some from it.
Thank you.
So thank you.
Thank you. Of course. The one thing I'll say is, so my presentations are in Canva, which is like a program, and they don't transfer well. So what I'm gonna have to figure out how to do is take out all the videos. So it's not gonna look as pretty, but the content will be there.
Will the screen in the back, like the slides that you had, will they be on the recording of this?
Yeah, I think.
Okay. Well then.
Yeah, because it's a video recording. Yeah, so it should be there.
So I think that'll be good then.
Shelly, I'll share this on EMS1, but I'll also put it on the YouTube account for us. So you'll be able to access it that way.
Okay. Thank you.
Sweet. Hey, this was great. Thank you so much. I like I said, if you have if anyone has any feedback that they want to tell me, please let me know. Let Lindsay know, because I'm always trying to improve what I'm doing, right? And this is a constant effort for me to. One of my passions is taking these complex physiological concepts and being able to deliver them in a way that anyone can digest and use. Because I think if we maximize how many folks can utilize it, we then in turn maximize how many patients have a better outcome because folks have this understanding. So that critique is crucial to me, and I really value that. You're not going to hurt my feelings. Please let me know what I can do better. So the next group, I can do a little bit better. Like I said, I really appreciate your time. Lindsay, please have me back whenever you want. I love doing stuff like this.
Absolutely. Thank you so much for joining us. It was an absolute pleasure. Hopefully, we'll be able to do something again very soon.
Yeah, absolutely. Absolutely. Thank you so much, guys.
Yeah, thank you so much for joining. I appreciate it. Thank you.
Let me stop sharing my screen. Yep, of course. Thank you so much. Have a good night. Okay, guys.